So hello and welcome to the PT's PT podcast. I am your host, Dr. Sean Lordan, and today I've got Dr. Eric Folmar.
Thanks for having me.
Yeah, Eric, we're excited to have you, and just give us a little background on yourself and your career.
All right. Well, like I said, my name is Dr. Eric Folmar. I am an associate professor at Northeastern University right now. That is my full-time life. Additionally, I own a small private practice. I've been practicing now, I hate to say, for over 20 years, which is a little crazy. Most of my career is in orthopedics, although I have a unique niche specialty. I've kind of followed my daughters and their love of Irish dancing, and I built a private practice around specializing in the treatment of Irish step dancers. So that's kind of where my practice came from, which is not many people can say, which is kind of fun. But it was great because it kind of built off of my love of foot and ankle biomechanics. That's kind of where my career really, that was the thing that I latched onto most as a practitioner. So I built that as a practice. I've followed some other passions. I currently sit on the board of a foundation called the Haley Kramer Foundation, which is a foundation whose missions really are geared towards helping individuals or helping physical therapy students further their academic endeavors. It also supports families that have suffered trauma and cancer research as well. So that's been near and dear to my heart, which has been pretty great. I am a father and a husband as well. I have 3 kids, sophomore in college now, a senior in high school, and a sophomore in high school. So that's me in a nutshell.
So you got a full plate. And I feel like, Eric, so I've known you for a long time. And
yeah.
I feel like you've always had a lot of, pots on the stove, and really you've done a lot of things well. So when I see that happen, usually people they skirt around things, or they don't really accomplish everything they want to get done. Mm-hmm. And you seem to have been able to do it all. So
appreciate that.
Talk to me about, how you successfully, sort of navigated roles, both clinically and academically. I guess what experiences in each of those have informed and enriched the other?
Yeah, so I mean, it's a great question. Yes, everybody always says you're really busy, and I am. I'm very busy, but I enjoy everything I do. Most of my professional career has been grounded both in academics and practice. So, how do you merge those things together? When I started in clinical practice, I knew I liked teaching. I liked serving as a clinical instructor for students. So I started to develop some of my own content that I then traveled and taught across the country. I really enjoyed that. And then had an opportunity to get involved at Northeastern with the anatomy program first. So I came in and started to adjunct there. I really loved that. And that role started to grow. And probably over a period of 6 to 7 years, I slowly flipped from being a primary practitioner to more of a primary academic. But I really wanted to still own both roles. So I have just kind of continually carved out portions of each to allow me to really still be invested in both sides of it, which has really, I think, allowed me, teaching is a huge part of what we do with patients, but having a strong clinical background is huge in my interactions with my students. I get a lot of feedback that students appreciate that I bring in clinical examples from the day before, from the week before, So I think it's also allowed me to evolve in both as practice has evolved and as healthcare has evolved. So I've tried to maintain that, and I think that's important to maintain. I'm not sure I'll ever be an academic without being a clinician, and vice versa. So I do hope to maintain that as long as I can.
Yeah, and I feel like as a student, and I know really as a PT, you want professors and you want coaches and educators who are doing the weekend course, you want them actively in the clinic, mm-hmm. right? Because that's sort of, you're practicing what you preach. Yeah. And it's so hard because you have to balance. It's tough you can't be full-time in both because there's not a 36-hour workday. So talk to me about those challenges.
Well, and I think it's not to minimize those that aren't clinically active, because I think you can still be very current and not be truly active in the clinic. I just find that for me, it just allows me to bring what I'm teaching to life. Yeah, there's time constraints. I treat right now at my practice, I treat about 10 to 12 hours a week. I treat one night a week and on Saturday mornings. But my practice is super flexible. I own a cash-based, small private practice, but it's out of my house, I do go to patients' homes as well. But I've got it set up where patients book themselves. They manage their own side of things. So for me, the administrative piece, there's very little burden there, outside of my standard documentation. I don't deal with insurances. I don't have those other headaches. So this has allowed me to practice and practice only while I still do my full-time work in the university. Does it work for everybody? Does it meet everybody's needs? No, but it fits my life really well. And it'll probably change over time.
Yeah. Talk to me about the courses that you were teaching across the country.
So I've done a lot. Biomechanics was where I first started. So foot and ankle, lower extremity biomechanics. I had some coursework that I taught there. And then I do a lot with taping techniques in the clinic. I am a big believer in the use of tape, both as a diagnostic tool and as a treatment tool. So I had developed kind of some of my own coursework, some based in kinesiotaping, some based in corrective taping, but kind of how to merge those together to be very effective. And to be honest, of all the tools you learn clinically, taping has been the one I've used from beginning to end in my career. It's been very effective. It's where actually my research is now focused as well, as at least part of it. So again, I've kind of merged all of the things that I do, both into my academic and clinical lives. So it allows me to take those real-time experiences and now use them in a research platform as well. So that's what a lot of my coursework was initially, and then, like I said, I've just advanced it from there.
How do you feel like your treatment has changed since you were like a few years out of school, just learned taping? Did you learn taping on clinical, or did you learn it?
I kind of picked up some of it over a period of time. I learned some in some courses. Then I dove in and I became certified as a kinesiotape practitioner. Yeah. I think what I realized very quickly with all the tools that I was gathering is I didn't buy into, like I wasn't all in on any one method, right? Like the tools you're taking in are, again, you're just expanding your toolbox, but you have to learn how to use them and when to use them.
And tell our audience what you mean by tools.
So treatment tools like, different types of soft tissue work that you might do, like instrument assisted work or dry needling or taping or, active release techniques or other pieces. There's lots of different ways to accomplish a lot of the same things. So I think the more tools you gather, that's fine. You can gather all those tools, but you really have to have your own thought process behind it, right? You have to have your own clinical reasoning behind it. So I think that's where, when I started learning about taping, for instance, I honestly don't buy into all the kinesiology or the kinesiotaping theory and philosophy. And a lot of people, the research doesn't necessarily support all of it either, but there are clearly things that do work. So trying to understand the reasons why, the pain science behind it, the biomechanical principles behind it, understanding the principles of the tape itself, right? And so getting very critical behind the tools that you're learning and trying to figure out what it is that works, why it works, and how do we leverage that in our practice.
Is there anything you're doing clinically today that you feel like the research just hasn't caught up to yet?
Taping. Like flat out. I mean, taping, people will say that taping, the research is inconsistent in taping across the board. And all I can say at this point is that the research in taping isn't good. Yeah. And it's scattered at best. But if you really start to dive into the principles of taping, you can peel back what it is the research is actually saying and start to identify where the holes are. And I'll give you one technical example is there's been research regarding kinesiotaping and proprioception, right? That it doesn't impact proprioception of the joints. Well, yeah, I mean, the proprioceptors live in the joints. It's really hard to get tape to impact that. But the tape does impact your largest sensory organ, right, which is your skin. So if your brain can detect tension in the tape quicker based on its application on the skin, then you're getting additional feedback that you may not have gotten previously, right? So you have, even though the proprioceptors may not be impacted per se, you've augmented another sensory input, and there's a lot of potential there. And we've seen the potential in ankle sprains. We've been published in some of this work, and I want to continue to work into that realm.
Yeah, and I think that, your practice, and I'm sure your practice as it's evolved over time, is light years ahead of where our board certifications are, because they have to test, what we're getting tested on today was research that was really done 5, 6, 7 years ago and then vetted along the way with questions. And, I found that 10 years ago when I first became board certified. So there's nothing about dry needling. There's nothing about Graston technique. And those are the two things that we were doing clinically almost every day on patients. Not to put down the board cert, because I think it's really important to understand, different pathologies and diagnoses, and it gives you really a 10,000-foot view of everything you're going to see in the clinic. And I think it's a tremendous asset to any clinician of any age. But I think that the research, I applaud you for really pushing forward the research on taping and just research in general. Yeah,
and the board certification, just like our boards in general, yes, it is behind from a research standpoint, but it's really testing foundational knowledge, right? And I think that's where a board certification to me doesn't tell me that somebody is up to date in their research. They're up to date in contemporary practice. What it tells me is they've got a level of foundational knowledge that is focused and is above our entry level. And that's where I think its usefulness is, because you just kind of set the next level, right, for orthopedic practitioners. So I think the board certification certainly has a role. It does not tell me that the quality of the tools an individual uses in the practice, or are they up to date with contemporary practice. It just tells me kind of where that individual has set their new baseline, which is higher than most.
Yeah. No, and I totally agree. And we talk all the time, Brooke and I talk about, it's important to have an OCS, and I think it's tremendous, but it doesn't mean you're a great clinician.
No.
So I guess what to you makes a great clinician?
Somebody that, first of all, that's willing to recognize that, right? Like you have to recognize that letters don't mean anything in your practice, right? It's really about, how you approach every individual patient. To me, as a practitioner, I don't look at the tools. It's really about their ability to clinically reason, right? And that is first and foremost. I won't say diagnostic skills, because we're not necessarily supposed to do that, but I think your ability to reason your way through a scenario to get down to the most likely really focuses your treatment. So then you can pick and choose your tools effectively. Like, yeah, I dry needle for this. I use cupping a lot now. I never used cupping in my career, but now I've gotten it down to some specific diagnoses that I think it's really effective, right? So now I can pick and choose these tools, but it's all based on my clinical reasoning, and I think that's what really makes the practitioner what they are.
Are there any sort of technologies that you've incorporated into your practice, like laser or shockwave, that have helped?
Honestly, in my practice with my setup, no. It's with the type of setup I have and a very small overhead practice, it doesn't necessarily fit. I do think there's places for those things for sure. Again, we tend to, as a profession, I think this goes across healthcare. It's not just PT, but we find these tools and then we lay the blanket, right? We treat everybody with them, and then eventually you figure out like where it's most effective. So I think those tools have their place. Again, they are simply tools. So what is the best tool in a given situation? And, the research the science will certainly help us with determining some of that. But yeah, I think the jury's out on some of it for sure.
Yeah, and to your exact point, I think the best tool is a clinician's brain.
Without a doubt.
Getting to the point where you know what's going on, and then for the younger PTs, just enhance your toolbox, but don't hone in on just one thing. And like you take the dry needling course, you dry needle everybody for 6 months.
Yep.
And you get good at it, and then everybody needs dry needling. You get a shockwave machine, everybody needs shockwave.
Yeah.
So
it's interesting you say like the dry needling. It was funny when I first took dry needling, I wanted to dry needle everybody, but I wasn't sure where it was going to be best. So instead I dry needled nobody for a period of time.
Yeah.
And I was like, well, this isn't great either because I have to practice the skills. But it took me a while to figure out how I wanted to use it. So I am super skeptical of just walking in and just doing something because I just learned it, right? So it took me a little bit to wrap my head around where it might fit in. But I know that's probably not a conventional way of thinking. But
how far into your career did you take the dry needling course?
Only a few years ago, to be honest. I think, probably just before COVID, probably is when we did that. And yeah, I'm still learning dry needling. I still trying to figure out where it's most effective, kind of what the best applications are, what the best patterns of needle, so I got a ways to go in there for sure. It took me a while to latch on. I think it's kind of that same mindset. Like I like to see how something is working for a bit, like just observe what the impact is and try to figure out where it might best fit before I dive into it. So, and that's just how I approach everything.
And I think it's good information for a younger PT because when you just graduate PT school, I mean, we see a lot of kids getting certified as students now in dry needling. And I'm like, that's a little dangerous because now you get a tool in your toolbox that you may not diagnostically if we're not using the word diagnostically, if you don't have a pure or a really good clinical reasoning process, you're just going to dry needle everybody versus you got dry needling certified 15 years into your career.
Right.
And you already have a robust toolbox. So you're like, this is where it fits in, and it's not going to be on every patient. Right. So I think that's something to think about as a new grad. Is like, okay, when you get when you get Graston certified, you get dry needling, you get spinal manip, you get taping. The foundation is important too.
Yeah.
Absolutely. What are we treating? Are we treating a chronic pain patient? Are we treating acute pain? And kind of just the clinical reasoning skills are really important.
For sure. That underlies everything that you do. And if you're not practicing that way, you're missing the boat.
Yeah. So as the associate department chair, you've led significant curriculum changes for the past 5 years, from 2020 on through COVID. What were the driving factors behind these changes, and how do you prepare students for the evolving demands of PT?
That's a challenging question on a few different levels. So there's a lot behind the curtain in academics, which is, we won't get into the depth there, but there's a lot that go into curricular changes. There's a lot that go into the decision to make the change and then to actualize it. So we implemented a new curriculum. Quite literally, our first cohort was this that we were bringing in the new curriculum was the start of COVID. Yeah. And we were phasing out an old curriculum. So that was just kind of a nightmare timing wise, but the ship had already sailed when we started this. So, the goal of bringing a new curriculum is how can you deliver content most effectively and most efficiently to meet your students' needs, right? And now there's these other demands like the cost of PT education and other things that are putting a lot of pressure on this and to shorten the time from beginning to end. But in the same breath, the scientific database is growing exponentially, right? So what do you not teach? And that becomes a real tough balance. And then we're bound by our accreditors as well, and the accrediting body, CAPT. They tell us kind of what we have to cover. So trying to figure out all of those pieces and designing a curriculum that will meet our accrediting needs, meet the student needs, and meet our requirements to our university, right? We're a small program in a large institution, so we certainly have to play our role and meet our requirements in the institution. In the end, we have constant communication with our clinical partners, with our alumni about, the effectiveness of the curriculum. We've actually re-embarked on a new assessment journey, really kind of reimagining how we assess. We're great at collecting data. Our assessment of that data maybe was, we need to fill in the blanks there. So we've recognized that and really started that process. And technology will allow us to gather more data, which is great, so we can piece that all together. But I think in the end, we see, anecdotally, we see what our student end product looks like. And actually, one of the things that brought me to Northeastern was, as a clinician, I loved the Northeastern students as they came into the clinic, and I was like, that's what drew me there. So I was fortunate to get my dream job at Northeastern. A place that I really wanted to work. And so now I'm kind of going around, but now we're like, come back to the curriculum, like, now how do we continue to take this great foundation of a program and allow the curriculum to evolve to meet contemporary practice needs, but still maintain the identity of the Northeastern program. Co-op is a huge piece of the program, but that might need to change a little bit to kind of meet contemporary needs. There's a variety of things that need to change, and the way we've been approaching curriculum is, nothing is off the table, right? Like, how do we engage with all of our stakeholders, students, clinical partners, faculty, to make sure that the curriculum meets its needs, and it's an ongoing process. So yes, we put a new curriculum in place. We've already reimagined it 2 or 3 times since, and we're literally in the middle of that process now to make it better.
What are one or two of the biggest shifts that you guys made in 2020?
Well, we went to an all-graduate curriculum first and foremost, which gives us a little bit more flexibility from a university standpoint. So as soon as when you have undergraduate students, you're bound to the undergraduate processes of the university, which technically are they're a little bit more strict to meet undergraduate needs. Accreditation for the university is a little different on the undergraduate side. Costs of running the program are certainly a big piece behind that as well. So that was another reason. So the shift there was the bigger piece, and then just kind of resequencing all of the curriculum. We shortened our curriculum by about 4 months at that transition as well, and we're still long. Admittedly, we're still long, and we're on the expensive side. And I think those are two things that we're trying to figure out how to put together. Co-op complicates that, but co-op is such an important piece. So in the end, we have some amazing faculty, we have great leadership, and we're trying to, again, maintain that identity and still meet the needs of the students going forward. And again, you see our students here. We have great students, so that we always keep that in mind. That's the end goal.
Yeah, and cost is a huge thing. I mean, you see these hybrid programs like Tufts coming out, and I know they've had some issues in their first couple cohorts with the length of program, and but cost is a real question. It's especially with what and you're in private practice, the insurance companies, and our premiums, for our health insurance for our company go up 10% every year, but oftentimes we see a 2 to 3% increase in reimbursement.
Right.
So it's tough, and this podcast isn't about the business side of PT,
right.
But we need to make sure that the degree makes sense, and that you're able to deliver a quality product at Northeastern, and that when they graduate, they can make hopefully what should be a 6-figure salary.
Yeah. And I think I do think the degree makes sense. I honestly do. I think we are doctors for a reason. I think we have yet to realize and actualize that clinically quite yet, which is probably why reimbursement hasn't followed suit, to be perfectly honest. But yeah, the cost of tuition cost is extreme. I have a kid in college. I have another one coming. It's insane. But in the same breath, I would still recommend, like my oldest, she wants to be a PT.
Yeah.
I have no problem with that. I think it's a fantastic profession. I think our opportunities are going to continue to grow, but we're certainly in the middle of a lot of growing pains, and the dollars and cents are a big piece of that.
Yeah, and there's a real demand for physical therapy with our aging population, and there really is not enough PTs to go around right now.
Right.
You know, and I think eventually the economics of that will catch up. I hope, because I think we're pretty important for the healthcare system, and I'm sure you share that sentiment. But I think that, you know, I see a positive future for PT for sure. So it's exciting to me to hear that you are pushing your daughter into it if she's looking for that, you know.
I'm certainly not pushing her, but she loves it, and I want to encourage it, and I certainly wouldn't push her away. That's for sure.
Yeah, that's awesome. Northeastern and Duke. Talk to me about the collaboration.
So
it's pretty exciting.
This is actually really exciting. This has been a little bit of a challenging journey. But a good friend of mine, our now APTA president, Kyle Covington, him and I were sitting down one day talking about so Duke started a residency. They've had a faculty residency now for maybe 10 years. I should know that better. But, you know, this concept of we have residencies and fellowships for clinical practitioners, and then suddenly we're asking clinicians to move into the academic space and be effective academicians is really, it's kind of backwards thinking. You know, that just isn't really how it happens. And I've had great mentors, but I've had to learn the hard way about being an effective faculty member. So, you know, we sat down and talked about how can we bring two universities together. So that is, you never really hear much about universities coming together to work on things. But we saw an opportunity where Duke already had the framework and an accredited program. How can we, but they're growth limited, right? You can only have so many faculty residents in their program. So we thought of how can we expand, allow them to grow, but be a part of this and help foster additional growth. So we expanded this program, first of its kind, where we now host residents at Northeastern. They are part of the Duke faculty residency, so they do all the didactic work remotely, but they are employed residents at Northeastern, so they are embedded in our faculty and with our students. We now have two residents in our program, and the relationship has been fantastic. It's really allowed us to open up the partnership between us and Duke. You know, the collaborative nature of the program has allowed us to bounce problems off each other, to develop creative solutions to different things. But really, just in the end, we're kind of all trying to swim in the same direction, right? And this just kind of helps to foster that. The residency since has now brought on multiple other institutions. I believe now we have Hawaii Pacific has joined us. Sacred Heart has officially joined us. We have several others that are in the pipeline. And it's really, we're creating this network of higher trained, entry-level faculty, which is, you know, like I said, there's so much behind the curtain of academic life, and it's a great opportunity to expose individuals to that in a more protected setting, right? But they are faculty when they come on board, but we have a process of mentorship. They have didactic work that they do. They have an opportunity to get really close with a lot of the students as well, and it's really been great to see it grow. We actually have a grant from the Foundation for Physical Therapy Research to look at some of the outcomes related to this. So we're in the process of a pretty large study with that as well. So we're really excited about the potential of this going forward.
Yeah, I mean, that's pretty neat because, you know, there's clinical tracks galore, right?
Mm-hmm.
You have all your clinical specialties and your fellowship tracks too,
Yeah.
But there's nothing really on the business side either,
right.
other than an
Exactly.
MBA,
Yep.
you know, so you get that. But I think it's a really tremendous way to, you know, maybe jump from that faculty member or that the clinician who's, adjuncting in a lab or, a
Right.
lab assistant TA, but really wants to get into education, applying for a program like that could be really special.
Yeah, and being a lab TA is great, but that's just it's like being a clinical instructor, right? You're teaching your clinical skills, but understanding education and pedagogy and all of the things, and just navigating the academic institution life is really complicated, and it's a scary jump for clinicians to move to academics, but sometimes it's a necessary jump, right? The academic life does give you some more flexibility. So if you have a family life, or you're later in your career and physically the clinical life is a challenge, the academic life provides a lot of opportunity. For me, it wasn't about those things. It was about having an opportunity to impact a lot of students. But it's a scary jump, and the residency is really it's far exceeded what I had hoped. And the again, the collaborative opportunities between us and Duke for sure have continued to grow, and I'm just excited for where it's going to go in the future.
Yeah, that's awesome. You develop programs to expose high school students to health sciences and PT education. Talk to me a little bit about that, and how you've been effective in engaging sort of underrepresented communities in PT.
So, I'm sure you can ask a bunch of your clinicians, like, why'd you become a PT, right? Yeah. And most of them would tell you, I tore my ACL in high school, right? Or I had PT in some way, shape, or form, or a loved one had PT. But they've been exposed to it, right? And they saw what it can be. But there's a lot of individuals that don't get that opportunity to get exposed to health sciences, especially in underserved communities where, the resources may not be available to maybe have anatomy programs or health science related programs in their high schools, or maybe it's some of these communities. I'm fortunate we're in Boston, where there's healthcare kind of everywhere you turn, but in some other communities you may not have access to healthcare, and so you don't get exposed to those things. So I was able to join up with a pre-college program at Northeastern, where they do some different pre-college work across the university. And we have a human anatomy lab on campus, which is a unique feature to a lot of universities. And so we decided, how can we expose individuals to anatomy, and then to health sciences in general. We have some amazing research labs. We have a simulation center, biomechanics labs. Like, how do we get people to see this? So one day, literally, we started, in my daughter's high school anatomy class. I was at one of her parent-teacher nights, and a teacher was showing me the dissection of the human eye, or not a human eye, maybe a bovine eye or something like that. And I was like, the light bulb went off, and I said, hey, we have an anatomy lab. I'd love to get your students in, and boom, that was born. A couple months later, we had 75 students in to see our human anatomy lab. We also in the lab have a digital space, so we have a digital cadaver table. We have a synthetic cadaver, and we have some other unique anatomy teaching tools. So we had the students in there. We also had them in to see our simulation lab, to see the campus in general, and it was just the feedback from that was outstanding. We've since had that program in 3 consecutive years, and every year they want to come. But what we realized, it was a great opportunity for us to expose students to sciences in a different way. So it wasn't necessarily PT specific, but just to expose them to sciences. As the program has evolved, though, we've kind of created this opportunity where we have our PT students are often in open labs. They're looking to, practice their skills, practice their patient interactions. So part of the experience is actually the high school students that come in actually serve kind of as the student patients for our PT students in their open lab times. It's an informal kind of organic setup where they basically like, here, go meet your student PTs and have at it. There's no real structure to it. And what we found is once they start to interact, they start practicing their skills. They start to kind of feed off of the high school students that are there, and I don't know, it's just really developed organically in a way to talk to these students, and eventually they start talking about how they got into PT, how they got in, what's PT education like, and it's been really cool, to be honest. And we've had a good handful of students have written and said, hey, I've decided to go into PT, and I'm in large part to this, or this solidified my want to be into PT. Some we've gotten feedback, it solidified that I don't want to be in anything health sciences, which is
the formaldehyde.
But it's great. Like, you're deciding what you want to do with your life, and you're going to walk in day one and be like, oh, I don't want to do this. This is not for me. But you have opportunities to get exposed to it ahead of time. So we've now had 350 students through 4 different local high schools. And we have 2 more high schools that are interested in coming, and that program is slowly starting to grow, and we really look forward to it. That's been fun.
That's amazing. And you talk about the communication, right? And so the students interacting with the high school students and really using them as patients, right? Mm-hmm. Talk to me about, in your opinion, Eric, what makes an excellent new grad physical therapist? What does that PT look like to you? Versus just like one that will succeed, but not. What brings that new grad PT to that next level?
I think initially their mindset coming in is one that's that's probably the most important thing to me. Is a couple things. One, recognizing they don't have all the answers, right? PT school. You may not learn all of the best ways to treat somebody, but you certainly know all of the things to look out for to make sure you're not doing anybody any harm, right? So, making sure you're using those tools to first make sure somebody is appropriate to be there, and then being open to learning those new techniques about how to best treat somebody. And, I think being open-minded with that is certainly is key. You feel like you've been in school for 3 years, you're armed with all this information, you feel like you know everything, and really you're just at the tip and you're just getting started, right? So, I think owning that early on is important. In the same breath, I think, the advice I give students when they leave is be every bit of your doctoral degree. Like, you are a doctor. Own that. And I think and make sure that you treat every patient that way at that level, right? And even in your interactions interprofessionally with other healthcare providers, we work with physicians, you work with other rehab providers, those interactions, you have to own those at the level of a doctor. And if you don't feel like you're comfortable in certain areas, then you have to develop those. But you have to own that. You're graduating with a doctoral degree. You need to be that for our patients, for sure. So,
yeah, I think that's great advice. And I think anybody listening will, and really to me that screams professionalism.
Yeah.
And to us we call that 1% better every day.
Great.
But sometimes it's just as simple as dressing the part. Mm-hmm. I'm not shaved right now, but in high school we had to shave. I would get a detention at St. John's for this. But looking the part, dressing the part, that all matters. How patients perceive you, and there's a level of respect in that with our degree.
Yeah, you can't go through the motions. Every patient, and again, I think, it's hard. Students come out there looking for a job. They want to find their dream job, and then they tend to fall into the system, right? I need to see a patient X number of visits for this or that. That's just fostering the problem, for us and for healthcare in general. I think you have to be willing to stand out a little bit and be willing. In my practice, I see some patients maybe twice a week. Some I see once a week. Some I see once a month. Some I see once whenever they feel like they need to come in.
Yeah.
I have other patients I've seen once a week for 5 years because they, it makes them feel better. It's a healthy relationship. I think PT can be a lot of different things, and it means a lot of different things to different people. So, I think we have to be willing to own that.
Yeah, there is no set plan of care in a box.
Yeah.
And I think that that's, as much as you want to train that, it doesn't exist.
For sure.
We, at times we've talked about, with my clinicians, especially if somebody's in chronic pain and they come in with low back pain, like I want them here 2 or 3 times a week for 2 weeks, just to get the ball rolling,
right?
Like get them feeling different, better or worse. Sometimes they feel worse. And it's like, well, I can change my attack, right? I change my plan of care within those 2 weeks to, especially for low back, you could, whether it's flexion or extension or neutral or however you're treating them, pretty much in 2 weeks whether what you're doing is working or not, but I always say, like, get off to a hot start. But to your point, I mean, we both treated patients, I'm sure, for years and years and years once a week who just need PT, or value it in a different way.
Yeah, I would say, I don't think anybody, and I like how you changed that. I don't think anybody needs PT.
Yeah.
There's, we value different things, we respond to different things very well, and I think that's the important piece. But
yeah, no, that's great. So, serving as the president of the APTA of Massachusetts, talk about the initiatives that were really close to your heart and that you championed there.
So, it's interesting. I never saw myself. I've been a member of APTA since I was a student. I think it's a professional responsibility. And I really didn't get involved. I won't get into the story, but there was a lot of reasons I wasn't super involved with APTA up until, about 8-10 years ago. In 2019, I became president, and 6 months after I became president, COVID hit. So a lot of the initiatives that I had envisioned kind of fostering and growing from our previous president, Heather Jennings, those all went out the window. And I was in management mode for the better part of 2 years, really. And then
during a critical time, of our profession, really, it was.
Yeah, and it was, it was very rewarding. It was a challenge, but it was great to see the PT profession, especially here in Massachusetts, come together and try to better serve the communities, which was awesome. But in the same breath, most initiatives were gone, right? Like there was nothing we were offensively working on until my last year. We started to grow, but I've been fortunate. MK Miller followed me as president, and I've continued to roll on the board as chief delegate. So really, during both my and her presidency, we've had an opportunity to work on a lot of things. I think my biggest, initiative during COVID and beyond has been establishing collaboration. As a profession, we've spent a lot of time protecting our profession, and in the same breath, we've become very guarded with other healthcare providers. We've protected our scope of practice so tightly that it's probably impacted our growth and has certainly probably negatively impacted other professions like athletic trainers or chiropractors. And so tried to break down those barriers a bit to help athletic trainers, for instance, realize their potential. Their practice act is far behind what contemporary practice looks like. So how do we bridge that gap and do best by them and by our patients and clients? So spent a lot of time working on that. This year we're able to support a piece of legislation that they've put forward to help advance their practice act a little bit. But that's been it's been a lot of mending fences along the way. There's been a lot of contentious relationships over the years, and trying to break those down and respect those, but in the same breath recognize that we need to move on because we're, not to be cliche, but we're a small fish in the pond, right? And we need to all be working together to get what we need, and thinking that we can do it by ourselves is really, we're going to get surpassed in this field really quickly. So aligning ourselves with others, allowing others to realize their potential so we can also realize ours, has been a big push for me. The other piece, obviously, payment is a massive thing. We've had initiatives where, really more defensive initiatives, we've been able to successfully defend some things that Blue Cross Blue Shield, for instance, has done. But we really haven't actualized anything of significance in a while. And I think we're finally getting to the point where we recognize we have start getting ourselves out of this box and try to work with these payers in ways that are, that really need to break the trends of what we've been doing for the last, I don't know how many years. So we have established some relationships with the payers, but again, there's strength in numbers, and we don't have that right now. So, our professional association is small. Some of the private practice associations are small, right? And we can't impact change at that level. We've got to do it at a bigger level. We need people, we need resources to make these changes. And so haven't gotten there yet, but that is one.
Yeah, I mean, the payment initiatives, the payment initiative, Eric, it's obviously something near and dear to my heart too, because PTs should be at over 100. We talk about this offline all the time. The starting salary needs to be six figures.
For sure.
And for it to be a viable degree, and for it to be a degree that economically we're getting the best and brightest talent wanting to come pursue as well. Younger kids, high school students, would be remiss not to compare our degree to a PA or a nurse practitioner or a pharmacy degree and say, what's the outcome? And it doesn't matter how bad you want to be a PT, it's going to be economically viable. We need to make sure that it's competitive. And, we just went out of network personally with United Healthcare January 1st. And for the audience, they were 25% below our cost actually 30% below our cost to offer an appointment, which essentially means that we were subsidizing their visits. So, that's not fair to us. And, it's not fair to patients who have United Healthcare either. So, and that's not after, I called them and we tried to negotiate and say, hey, listen, here's our cost. We need a little bit of margin to be able to keep the lights on and to be able to continue to grow. And they said, hey, listen, we can't do it. So our goal, and I think many private practice owners think this way, is that they want to serve their communities, right? And we don't want to just go completely to a cash model where people aren't going to be able to access our care.
Yeah.
And so it's like, what's the balance? And a 2 or 3% raise just isn't going to cut it. No. Not after the inflation of the last 5 years, and quite frankly, the cost of of the education and what new grads want, what they're looking for. And I always say it's, from a revenue perspective, it's 33%, is going to be cost, so and it's got to make sense, from a management perspective and a business side. And we want to make sure that we're paying our PTs what they deserve, so when we go to the payers, we need to be armed with that sort of information.
Yeah.
And access is huge. There's not enough PTs.
There's not. And there's, I've spoken with some individuals in large hospital systems that are involved in billing, and, they have negotiating power. And I ask, how do you do this? And they say, well, we have large amounts of data, right? So they have the ability to negotiate at levels that we just don't have, certainly as individual practices and really as a private practice network at large. So there's got to be other ways to do it. I think the other big piece, and again, this is more idealistic, but I use the phrase, we've got to be every bit of our doctor of PT. Insurers still view us as technicians. They don't view us for what we are. So we've got to start owning that. We've got to start being that, and separate ourselves from the pack a little bit. And until PTs embrace that, it's a tough argument. It's tough to walk into an insurer and say we need to be paid more. Well, you're doing the same things that you were doing 20 years ago. Like, okay, you're right. So
yeah,
it becomes a tough argument. So
and if you look at payment, actually 20 years ago they were getting paid $150 a visit.
Right. Yeah.
And then it completely dipped in the early 2000s and late 90s, and now we're almost right back to where we were 20 years ago, which is, if you think about that, it's wild. Another thing, and I'd love to we're kind of wrapping up soon, but site neutrality. This is the hot topic, and it's a topic that nobody really wants to talk about. What are your thoughts on site neutrality?
Well, that goes back to what I was talking with the hospital system folks that I've talked with, and
share what site neutrality is for our audience.
So site neutrality, when you look at it in its simplistic form, is private practices get paid at a lesser amount than practices that are associated with hospital systems. And again, without getting too much into details, the costs for hospital systems, the cost of the practice is rolled into a bigger package, right? There's other costs within the system, so on and so forth. So rehabilitation is a small piece of the bigger package. But those hospital systems get paid significantly more for rehab visits than we do, or than private practices do. So there is this huge gap, and it makes private practice sustainability, questionable at best at this point. So, the aim is to get insurers at least to close that gap, right, between hospitals and private practice reimbursement. Hospitals, I mean, this is not a hospital versus private practice argument, but the hospitals will certainly say, well, we're obligated to take in, patients that don't have insurance, right? So they incur other costs that some of these reimbursement rates kind of encompass.
But we could do that too.
We could do that. Exactly. Right. Exactly. So there's, but again, I think that the bigger piece is negotiating power. That's really what it comes down to. And the large hospital systems have it and we don't. And,
but the other piece is transparency to a patient.
Exactly. So, understanding the costs that are rolled into those charges, where that money is going, is a big piece. I actually think the biggest bridge to site neutrality is just getting rid of these, this treatment-based codes in the first place. And I mean, that's a much bigger, hill to climb. And, I think in the end, though, if we can get flat rates for visits as opposed to this, then a lot of that stuff goes away inherently. But yeah, those are things that we're working. I mean, those are things that, again, we need voices, we need legislative power, we need insurers to be, we have a handful of people doing a lot of work, and that's unfortunately why we're not getting the places we need to get to.
Yeah. Well, I speak for myself and many other private practice owners and appreciation of your efforts, at the state level and at the national level for payment reform.
I'm happy to do it. I wish we could get further.
Yeah, and I'm here to help.
So.
I like to finish with this question. Dinner with any three people, living or dead, who would they be and why?
This is a challenging question, and I'm not great at names up front, but I'll start with one more of it's probably a typical, childhood sports fan, but I grew up in the Derek Jeter era. I loved Derek Jeter, watching him play through his career. To me, that was something that, I latched onto like through college, and, I'd love to meet him, sit down with him, pick his brain. I love the sport of baseball. That's just more the child in me. Like, I'd love to have dinner with him. Other names I've gone through in my head. One that's of interest to me, just because of the stuff that this person has seen or had seen, is Ruth Bader Ginsburg. Like, just... I don't even know what I don't even know if I could ask questions. I would just love to sit there and hear her talk, and just, I think that would be amazing. The third person's actually is my grandfather. He passed when I was early in high school. He had a massive stroke a few years before that. I remember so much about my childhood growing up, but I'm not sure I ever really got to talk with him in ways that I would love to talk with him now. So he's somebody I'd love to go back and have dinner with.
That's great. Well, thanks again, Eric, for joining me today. This was amazing. And anything else you'd like to share with our audience?
No, it's a pleasure to talk. I can talk forever about these things. The questions you ask are, if you could ask me any questions to get me going, these are them. So I really appreciate the opportunity to share, and hopefully this has some impact on people.
I've got one more question.
All right.
What excites you the most about the future of physical therapy?
Oh boy. I would say probably that it's what it's going to look like 10, 20, 50 years from now is entirely different than what it looks like now. And I think that's what's cool. And for me, having a daughter that hopefully wants to go into it, you know, she's still working her way through college, but I think it'll be awesome for her to see what, you know, and interact with this community, you know, what it is 10 or 20 years from now. But it's going to be different, and I think that's pretty cool.
Well, she's got a great mentor and dad, and thanks again for joining me, Eric.
I appreciate it. Thanks for having me.
Awesome.